Dear healthcare professionals, in this video I am going to share with you 8th case in the series on diagnosis. The series of interesting, uncommon and challenging cases which I came across while working in critical care. Videos are helpful for all healthcare professionals. I will share a real case that was presented to our hospital's emergency and subsequently admitted to ICU. In this case, not able to identify underlying problem while the patient was in ICU led to significant morbidity. I will walk through real scenarios so you can connect this story with real-life clinical situations. So, let's embark on this story of making the uncommon, interesting, and challenging diagnosis and how it impacted the patient's management and the outcome. Let's begin with our case. A 23-year-old man presented to hospital emergency who sustained injuries after road traffic accident. On arrival, he was conscious with stable vitals. While he was in emergency, he gradually developed increasing heart rate. After initial management, CT scan of whole body done as per trauma protocol. There was bleeding inside the abdomen with findings of actively bleeding vessel. He was taken to OT for immediate intervention to ligate the bleeding vessel. Bleeding was from some small vessel at the root of mesentery near pancreas. After procedure, he was shifted back to ICU. He remained conscious with stable vitals over next 36 hours. Thereafter, he started to develop continuously increasing heart rate again, reaching up to 140 to 150 per minute. After ruling out other causes like fever or pain, we immediately searched for the bleeding and looked into abdominal drain for any blood collection, checked hemoglobin and did fast assessment, but we could not find any evidence of ongoing bleed. Therefore, we suspected infection. But what is the cause of infection and where is the source? Post-operative infection appeared less likely to us in view of nature of surgical intervention. ICU team suspected duodenal perforation as plausible explanation to his tachycardia since patient appeared to be infected. We, ICU team, conveyed our opinion to surgical team, but team was not convinced with our opinion. Patient was started on broad-spectrum antibiotics. After 2 days, we noticed greenish collection in the abdominal drain. Based on this new observation, we did CT abdomen again with contrast and it revealed duodenal perforation in the third part of duodenum. Surgical repair of the perforation was done. Surgeons sutured the perforation. But it did not stay close and abdominal drain continued to increase over next 48 hours. Surgical repair was attempted again with Omental patch, but again perforation did not stay close. Thereafter, patient was managed conservatively as patient developed controlled fistula and he was fed through jejunostomy feeding tube. Later, patient preferred to go to his home country with abdominal drain and feeding jejunostomy in place for further management. Why ICU team suspected duodenal perforation? Since we were not able to find out the obvious cause of tachycardia, infection was suspected as the most likely reason. Again, the next question was, if it is infection, what is the source? We were not suspecting post-operative infection, so this possibility was ruled out. We considered most likely possibility duodenal perforation because of nature of injury near pancreas. But initial CT abdomen didn't report any duodenal perforation. This case reminds us importance of early and timely diagnosis of underlying problem. What could have been possible if we diagnosed duodenal perforation well in time and intervened early? If he could be intervened early, it was much easier to close the duodenal perforation and discharge the patient within 1 to 2 weeks' time in stable condition and resuming oral feed. With a delay in diagnosis of underlying cause of new onset of tachycardia, hence, surgical intervention, duodenal perforation got macerated and surgeon was not able to close the wound because its wall got very macerated and not able to hold suture. This patient stayed with us for almost 6 to 7 weeks and still he was not in a condition to be discharged at the time of transfer. So, delay in diagnosis led to significant increase in patient's morbidity. By establishing the underlying cause of tachycardia, hence, by establishing the correct diagnosis, we could have prevented significant morbidity endured by this patient. So, establishing an underlying diagnosis is an essential component of treating patients. Healthcare professionals should be cognizant of the possible complications in a given situation, as in this patient perforation presented clinically few days later and unfortunately, It was missed by radiology team in the initial CT abdomen, which was done on admission. On retrospective review, initial CT was having localized air collection near duodenal perforation. Misdiagnosis or no diagnosis can lead to incorrect treatment, complications, and potential morbidity and mortality. Hope this was an interesting case. If you like this information, please subscribe to this channel for more interesting and challenging diagnosis.